Okay, I think that seems to have settled down now, so I think we're ready to start. And Helen, I'll let you take over.
Great, thanks, Nicola. Welcome, everyone. So I'll just start with a bit of housekeeping. The session's going to be about 45 minutes long, and hopefully we'll have some time at the end for questions. We will be recording the session, so you can keep your camera on if you wish, but you will appear on the recording. Since there are so many of us, please stay on mute during the presentation, but feel free to use the chat for questions, which I can address at the end. And if you want to ask questions directly at the end, please unmute yourself and raise your hand. Or if you want to ask a question, I'm happy to see faces, so please turn on your camera if you'd rather ask your question that way. So just a brief introduction then about me. I'm a research fellow based at the University of Hertfordshire in the School of Health, Medicine and Life Sciences, as well as being a senior advisor working for the NIHR Research Support Service in the Centre for Public Health. I'm a mixed methods researcher working mainly on projects in kidney disease and the mental health of children and young people relating to mobile phone use. I started my career in public health and I've got a master's in epidemiology. I worked as an analyst for two previous forms of the UK Health Security Agency, formerly the Health Protection Agency and Public Health England. So I have some insight into the kind of work that you do. I've also worked in public health teams in what was Hammersmith and Fulham PCT, shows my age, and also Harrow Council. And I've worked as the London data lead for the child and maternal health, for tobacco control, as well as collecting national data on childhood immunisations and HIV and STI. So I've got quite a lot of experience in sort of local authority related data. So just moving on to the next slide. So first, I just want to explain what we mean by the lived experience. So let's define it from the outset, what it is and what it isn't. Having lived experience is a form of expertise. A person will have knowledge and insight not shared by everyone. Their expertise may be in relation to a physical or mental health condition, experience of an issue, situation, or of accessing and using a service. The knowledge and insight they can bring is more likely to result in impactful research. This allows us to reframe knowledge and mitigates against the bias that can occur in the representations constructed by other people, for example, service providers or commissioners. Participants of research are also likely to have relevant lived experience, but as participants, their role is very different than individuals taking part in community engagement activities in the form of advisory groups or as part of co-design of services or interventions, which I'll talk a bit more about later. The difference between public or community engagement and being a study and a participant is the purpose. Being on an advisory group as a person with lived experience, for example, is about shaping the design of research, perhaps even the question, deciding on the data you want to collect, and helping to decide how you might share the findings. The input from an advisory group with lived experience at key stages in research can provide vital insights. As a research participant, a person is actively involved in the study in that they're providing data or they're part of an intervention. Reaching out to local organisations like community centres and support groups, attending community events and using social media or forming partnerships with local businesses or via existing programmes or initiatives that are focused on engaging people with lived experience can be good approaches to starting your research. Organising meaningful engagement can be time-consuming, and paying for people's time or incentivising involvement can be important. So I'll just give you an overview now of what I'm going to talk about in the rest of the presentation. So now we've got a shared understanding of the term, I'm going to talk about the importance of lived experience in relation to the local context and how it might enhance the use of local, regional and national data you already use to inform your health needs assessments, commissioning plans and other similar things. As I said, I'll go through some of the examples of my own work, which I hope you'll find interesting. So on the next slide, we're going to look at how can lived experience enrich research. So as I've said, people with lived experience may be invited to be participants in research or asked to be public contributors with a role in co-designing or informing research ideas and priorities, or being part of an advisory group active throughout the research process. So research is different from service evaluation or quality improvement. It's more of a systematic process that's aimed at generating new knowledge and helping us think about determinants of health, interventions and policies. And it often should follow rigorous methodology. Quality improvement, on the other hand, focuses on the continuous data-driven efforts within specific settings or organisations to enhance the effectiveness and efficiency of existing services and care delivery, and you may be involved in some similar work. Service evaluation aims to assess how well a specific service or programme is working in its current setting. It focuses on measuring outcomes, effectiveness or satisfaction within that particular service, without necessarily trying to produce findings that apply beyond it. So on the next slide, here we've got some examples of the activities local authorities are involved in and the types of data sets that might be used to inform these activities. So on the left are examples of routine data, and you'll all be familiar with these, so I don't need to go through them, but examples are the ONS mortality data, life expectancy data and cause of death, the childhood immunisations kind of data, and data from health and social care. Some of the secondary data sets will be things like the census and demographic data collection, the public health profiles and dashboards that I've been involved in generating in the past, and then data from crime and community safety data. So all of these data available at national, regional and local level will help you in doing some of the activities around commissioning and service planning and your JSNAs and those kind of activities. Okay, and the next slide. So whilst these data are very helpful, you will all be aware that there can be issues with granularity. Data may not always be available at the geographical level that you require, and data collection and reporting cycles might not always be timely for the purposes of using the data. There are also data gaps. For example, data on informal care can be poorly captured, data on travelling communities and migrants, and it may also be difficult to access private sector data. An example of when we don't always have the data that we need is when COVID hit and the government had no idea how many care homes there were, which underlies the importance of capturing data. Data quality and coding issues can often challenge us in a meaningful use of the data. And sometimes there is a mismatch between data. So we have to use proxies, which might underestimate unmet need. So quantitative data tells us what's happening, but not always why. It can be hard to design a person-centered service using only quantitative data. And in implementing any change, it's important to see the service through the eyes of the service user rather than the professional delivering the service. We move on to the next slide. So at the local level, looking for patterns in the data, but also in local narratives is important. Local delivery decisions should be people-centred and contextually relevant, not just evidence-based. Conducting meetings with community members provides an opportunity to systematically understand the local experience and identify where there are common themes, overlap between individual stories, and disparities between groups of people with common identities. Quantitative data may show trends, but also anomalies where the lived experience may provide an explanation. So an example that I have from healthcare is that some women from minority ethnic groups may also face an implicit bias from healthcare services, as well as systematic barriers when they're trying to offer access, for example, gynecological care. So these same factors can then negatively affect their adherence to treatment. And by this, I mean whether a person follows their treatment plan. So here, the data may suggest poor health-seeking behaviour in certain groups or low adherence to treatment. But actually, the reality for some women may be that they're not receiving person-focused care and experience more significant barriers to accessing services. So combining quantitative data with qualitative lived experience, public health teams can design targeted and culturally sensitive interventions. They can train staff in culturally competent care and unconscious bias, and they can partner with grassroots organisations or community groups to build trust and improve awareness and access. So qualitative data, I'd say, is really important in helping us think about what's working and what's not, and helping us to use that input from the lived experience to build really sustainable services that allow for improvement and accountability. So in the next slide, just to get underneath some of these things, we really do need to involve people with lived experience. And I've got a quote here from a public participant involvement and engagement group, so a patient advisory group. And I'm going to talk about this study a bit more later. But this group's involved in a piece of research in kidney disease, and all members of the group have chronic kidney disease themselves, or they care for somebody who does. So I'll just pause here and let you read this quote. So here, this highlights the importance of the communication loop, in that we hear the lived experience and then we act upon it, and changes are made to the design or the delivery of the study in light of what's said by a group of service users or a particular group in the community. So it follows the idea that you said and we did. And this quote here encapsulates the group's feeling that they really felt listened to by the research group, and that we were accountable. So we would hear what they said, we would make changes to the study design, and then we would feed back and say exactly how their contribution had led to changes in the design of the work. Okay, so moving on to the next slide. So there are existing tools and frameworks that can support conversations around the lived experience. And I've got two examples here on the left-hand side of this slide. So the Building Blocks of Health Toolkit sets out how we can frame communications to tell a more powerful story about health. So to increase understanding of the role that the wider determinants play in our health, things like clean air, feeling safe in our communities, and good quality housing, and then provide support for action to address them. So the toolkit is for anyone working and communicating in the field of public health. It's not a piece of work that I've been involved in, but it's something that I've heard about recently and sounds a really useful tool. So it's about trying to shift the tone and tailoring the message. And so sometimes better communication can be about reframing the conversation. So, for example, from why aren't you applying for the benefits you're entitled to what is missing that stops you being able to do this. So this is a sort of a toolkit really for having these kinds of conversations. The second example here is the community cohesion and population framework. So the aim of this framework is to provide practical guidance for anyone seeking to work with their local communities towards creating greater community cohesion. So the idea is that public participation can lead to the benefits both for the individual and the community, but also the public bodies that are trying to deliver some of these services, and can actually lead to greater empowerment within the community and sustained community cohesion. So I think both of those are quite nice examples of tools that are out there that you might find interesting and helpful. So if you are planning to set up a community stakeholder engagement group or to facilitate conversations about local views on key issues like housing, transport, local environment issues, then some of these resources might be quite useful. So place-based local initiatives that involve the lived experience of the community could involve things like urban planning, so where you're designing neighbourhoods based on lived experience and local feedback, where you're taking part in environmental conservation projects, so you're partnering with local communities to maybe protect ecosystems or do something about, I don't know, fly tipping or problems with rubbish. And then in education to maybe help develop curricula to reflect the local culture and geography. So those are just a few ideas. So, of course, doing research in local communities is not without its challenges, but I think there are also lots of nice opportunities. So some common challenges with this kind of working in a community engagement when you're trying to understand local needs or you're thinking about commissioning services include things like representation bias. So we're always at risk in research as well, academic research, we're always at risk of hearing the voices who are the strongest. So those people that are already quite good at advocating for themselves are more and perhaps more visible within the community. So one of the challenges, I think, is to make sure we're not overlooking the quieter or less organised communities within our local area, especially those that are perhaps already quite marginalised. And in this, we maybe need to think about language differences, where there might be issues with literacy levels, or we just need to think about how we're communicating with our local populations. Some of the practical barriers, well, we all come up against these, funding, limited time, resources. These are all very real barriers to meaningful engagement. But I think I'll talk a bit later about some opportunities for funding, but I think always trying to find ways to do things, even at a small scale level, is really important and can make a big difference. So I think trust and engagement, if people have had past negative experiences where they haven't felt heard or listened to, or they felt their contribution has been a bit tokenistic, we have to really work at breaking down any kind of mistrust and increasing willingness to participate. Similarly to the representation bias, we need to make sure that we are balancing conflicting interests and priorities. Not everyone's the same, and even people with similar lived experiences will have different views. So I think that can always be a challenge. And then also organisational challenges. We all know about those too: bureaucracy, existing cultures and norms that make looking at things differently a bit difficult. So I think I'll talk more about opportunities later, but I think, just as I mentioned before, I think some of these feedback loops can be really powerful. So involving your community, getting their views, and then feeding back. You've said and we've heard, and this is what we've heard, and now this is what we'll do. I think that's a really important part of engagement. I also think dissemination of findings is really critical, that we translate what we find in sort of academic context into something that people understand. They understand what it means, what the consequences are, what potential impacts are. And I think looking at using plain English language whenever we disseminate findings, and doing dissemination in kind of innovative ways rather than just producing dry reports is also very important. I think the last point that I've got here on opportunities around strengthening communication, I think that's really important. And I think doing things like offering spaces for people to meet and providing training for your own staff, but also training in the community perhaps to understand issues a bit better, some training in unconscious bias for your workforce, but also around cultural humility training, but also how to engage meaningfully with the local community. So moving on to the next slide. So I'm just going to talk a bit about co-design because it's become much more popular concept in recent years. And I think working with, as an NIHR advisor, we see this kind of buzzword come up quite a lot in grant applications. And it's an important thing, but difficult to do properly sometimes. So it's part of a wider social movement in which we're trying to share power. So it's about bringing together lived experience with other elements of expertise and key stakeholders to design something that actually is really relevant and fit for purpose for the community or population it's intended for. So it's where people with lived experience can co-lead the development, design, implementation, and evaluation of activities. So it's not about tokenism, it is about people really being embedded in designing and deciding what the priorities are and what the outcome measures are and all those really important things. So it's about trust and open communication, and actually the outcome of doing co-design well should mean that we're really enhancing social inclusion. So we're really making programs and services and things that we're doing more relevant and more inclusive for everybody, really. So there is guidance for conducting this kind of work. I'm not going to talk about it too much here because I'm not an expert in co-design, but I just wanted to flag this. The NHR have got some really good guidance. And just to say, that there are recommendations out there for how you should recompense your local community members who might be involved in this kind of co-design work, and how it's important to provide adequate training for people to be properly involved, and also to make sure if you are applying for funding to do this kind of work that you've got the this aspect of it properly resourced. So on to the next slide. So I'm just going to talk about 3 examples of work that I've been involved in that perhaps will help you understand the kind of things that I've done around the lived experience. And I'll try and highlight the difference between PPIE and then the involvement of community members as participants in studies. So I'm going to start first by talking about the Bootstrap study, which, if I'm honest, I think is a very unfortunate acronym. It's very long and difficult to say, but it stands for Boosting Societal Adaptation in a Rapidly Digitalising Post-Pandemic Europe. But it's essentially about the use of mobile technology and the mental health of young people. And in the last decade, concerns about the addictive nature of mobile phone use and access to the internet have risen, as I'm sure you're aware. And so a study has been designed and developed, which is looking at digital use on phones amongst young people who are 12 to 16. The study is being led by the UK, but it's in conjunction with 9 countries across Europe and 22 organisations. So the group is co-creating a digital screening and assessment platform, which to you and I is a mobile phone app, to understand which individuals are at risk for developing problematic use of the internet. So eventually they'll be using algorithm-based models to predict how individuals will benefit from self-management intervention. So it's very much focused on prevention. The group acknowledged the many benefits of internet use and mobile phones, but I think it's about supporting young people to use their phones safely. And so the results, they hope, will support development of a policy toolkit, which will be co-designed with stakeholders, and it's to promote human digital rights, accountability at all levels, really, at the local, national and European level. So it's an exciting study. I'm just going to move to the next slide and talk a little bit about the aspects of the work that you'll probably be most interested in. So a critical part of the work has been to involve young people, not just as participants, but also as ambassadors for the project. So we've used the Lundy's model of participation to engage young people across all of the 9 countries that we've got involved. And this Lundy model framework highlights children's right to participation, and it aims to help organisations and bits of research like the piece that I'm involved in to really comply with Article 12 of the UN Convention on the Rights of the Child, and to ensure that we are really involving children in the research and thinking about how this will how they can participate and be involved in this. So the way that we've involved young people as ambassadors is we have given them information about the study to translate and share with their peers. So we've really made sure that they're well informed about the study. And then within the schools that have been recruited to the study, their student ambassadors have gone back and they've done school assemblies and they've spoken to their peers, and they've really taken what we've got in the academic literature about what we want to do and translated that into something that other young people can understand and have really infused them to be involved. Because obviously we are looking, well, I don't know if I've explained that adequately, but we are looking at their use of their mobile phones. So we're tracking what they're doing on their mobile phones. So as you can imagine, it can be difficult to recruit children into the study because of the idea that there's issues around their privacy and confidentiality, which we have completely protected. But they are living in an era where everyone is conscious of privacy and worries about their data and how other people have access to that. So we've really engaged those youngsters to help us to communicate that message that this is done with their privacy in mind, and that actually they will be involved in something that's going to have a very positive effect for young people in the future, we hope. So we've also within that study given them the opportunity to participate in what we call boot camps, where they've been involved in the design and development of the app. And that one was in the UK and one was delivered in Portugal. So they had the opportunity to travel. It gave them access to researchers, to people who are really experts in the area of online addiction, and to learn about research. So to learn not just about studies specifically, but about research more broadly. They've also had the opportunity to join online meetings with other young people involved, and they're now telling us about their experience of using the app. So the first round of the study is coming to an end, and we're talking to them and engaging them in their experience of using the app and how we can improve the next round of recruitment, the next phase of the study. So moving on to another piece of work that I've been involved in. So this is a piece of work that I led where we explored what self-management means from the perspective of people receiving hemodialysis. And what we were doing with this, what we hope to do with this piece of work is really shift away from a medical model perspective around treatment, where self-management just relates to the hemodialysis treatment. And what we wanted to do was to make it more holistic. So I conducted 27 patient interviews, so that was with people who were participants in the study. These people had lived experience, and I asked about their experience of managing a number of topics, and a number of the topics arose. So in the top right-hand corner, I don't know how well you can see it, these were some of the themes that arose from those conversations. And they included things like support from the kidney team more broadly, communication, coping strategies. And I think healthcare needs often lead to social care needs, and that piece of work really emphasised that. So this led to the development of the items for the scale, and those items were then really rooted in the lived experience. And this narrative provided an alternative perspective to that kind of traditional medical model that just focuses on treatment. So there is an interdependence between chronic kidney disease and health and social needs, and people with the condition are often comorbid and sometimes frail. So treatment is intensive and expensive. Patients often have hospital-based dialysis 3 times a week. But the focus on the clinical delivery of care ignores the impact of engagement with health around, you know, the impact that social isolation, depression, treatment burden, low income, and presence of other long-term conditions might have. So actually, in the piece of work that I did, social support really came out as a really key factor in how people can engage with their healthcare needs. And it was interesting that we had looked at the literature and some of the things around adherence to treatment and dietary behaviour, which is actually really important to maximise the potential of the treatment, you know, to make sure that people are showing these behaviours that maintain their health holistically. Social support was a really big factor in that. So again, it just highlights that without the lived experience in this piece of work, we would have stuck to the questions around the needling specifically and things to do with adherence to dietary requirements and things like that. But instead, we managed to bring out the importance of things like mental health, social isolation, and wider support networks. So you've probably had a chance to read the quote in the middle there, but again, this quote just really gives you an insight into this person's experience, and that actually this idea that self-management only really happens when you're in the hospital having your treatment is just not true. Okay, and then moving on to one final example, I think I've got time. So this study called EDNA for short was awarded a programme grant to develop evidence for a larger later trial. So in this first study, we conducted focus groups with patients and carers to understand what matters most to them as they age and perhaps become more frail whilst living with kidney disease. So the ultimate aim was to design a primary outcome measure to be used in a larger study that was going to implement kidney-specific comprehensive geriatric assessments. So we brought on board a patient advisory group to help us to develop the materials for the focus group. So we've got the people involved in the focus groups being the participants, and the people in the patient advisory group being the community members that are helping us to shape the materials to be used with the study participants. So as well as helping develop the topic guide for those focus groups, they gave us some really, really useful feedback in terms of the terminology and the acceptability of some of the words that we were using. So, you know, quite often in a lot of medical things, terminology can be quite complex. And what the group told us was that actually this word frailty can be quite stigmatizing. And even talking about comprehensive geriatric assessments, it's quite difficult to get underneath what we actually mean by this. So their input into the work was really, really vital. And that translational aspect about taking what's written academically and turning that into something that people can really understand. So I'll move on now because I'm conscious that we want some time at the end for Q&A. So these are just some examples on this slide and the next, just about how you can bring the lived experience into your own research. So perhaps producing guides for conducting focus groups and interviews. There's lots of information out there that could help you do that. Designing ethics and consent templates suitable for low risk research is another thing that you can have. If you have some of these materials available, you might reduce some of the barriers for other members of staff doing this kind of work. Engaging local community and identifying barriers to accessing local health assets. So again, thinking about food banks, parks, clinics, as well as some more traditional health related things like GPs and local accident and emergency. Monitoring access to service. So again, getting some idea about equity of services, who's accessing them, and if levels are low amongst some groups, why? Perhaps going and speaking to those groups. And then encouraging that small, low-cost projects, also trying to support staff to look for funding opportunities. And then the last point here is just around setting up a journal club. So something quite simple, where actually you could discuss a topical paper monthly. You could look at whether it's useful. It might help build team confidence just in critiquing and understanding research. And it also might spark some ideas. And actually, even when you're looking at research ideas, doing small scale literature reviews is never a waste of time. You know, looking to see what's already out there in a particular topic area or what another local authority may have already done can be a quite useful way of thinking about what you might do locally. So if you're interested in getting involved in research, there are a number of NIHR funding streams that might be appropriate, including the public health research funding stream. I've listed a few things here. Happy to take questions about some of these at the end, but there's different amounts of money available. But I think just to draw attention to the Grassroots Awards, this is about fostering a culture of research within at the grassroots level, so empowering more individuals to contribute to research. And I think it's £5,000, but you know, research doesn't have to be big, and often great ideas start out very small. So that's just a few ideas there about funding options. So I've added this slide. I'm not sure. I think it's relevant. I think you might not be quite there yet, but it's worth thinking about. So this is drawn from some of the advice that we give to teams that are looking to apply for NIHR funding. And I think it's relevant no matter how big or small the piece of research you're doing. You always need to be clear on what the importance of the research is and to really understand the potential impact and to draw that out in your application. It's also really important to show how you'd have this public involvement aspect. There's no point in designing research where you haven't asked people in the relevant communities what they think, what their priorities are. So really think about doing that at the earliest stages and all the way through any work, any research that you might do. You always want to consider how you can make your research as inclusive as possible, and increasingly now funding really depends on this aspect, that you're really making the research, the service you're designing or the intervention or whatever it is as relevant as possible to as many people as possible. Thinking about your pathway to impact. So what are the mechanisms whereby whatever you're introducing is going to have an impact? Who will it impact? Why and how? And what's the importance of that? I think getting feedback is always really critical in everything that we do. It's nice to iterate your ideas and to always have people giving their opinion. It can be difficult to incorporate everyone's opinions at times, but I think it always helps in drafting something that's going to be fit for purpose and really relevant. And obviously writing, communicating in plain English. And I think, you know, working in academia, I see this can be a big problem. And I think using a shared language, trying to develop ways of communicating that get rid of the jargon and are more meaningful is really important. So remember that hearing the lived experience and incorporating the views of your local communities into research is essential in driving the inclusion agenda, that services should be relevant and accessible to all, irrespective of personal characteristics. So the spark for your research question may come from conversations when common themes or concerns are repeated, and the design of your research can be shaped by insights into what matters most and what you should measure perhaps to show that you've had success. So all the way through to including a community member in your research team who can keep you on track and provide oversight and keep you accountable. So, you know, you can really see how this the lived experience can be really important in all elements of research. So in summary then, hearing the lived experience helps us understand local need and really get underneath it beyond what you can discern from nationally produced tools and dashboards. And I think that whilst nationally produced inequalities tools are really helpful and local quantitative data has its value, I think what can be really enhanced is doing local surveys and using qualitative data in your local patch. So bringing local community members, providers and policymakers together, you know, it's an amazing thing to do. It's not a quick win in the short term, and it can be challenging, but it can have long-term benefits for community cohesion and sustainability. Small-scale research can have an impact in improving community health and well-being, and increasingly there are more funding opportunities for local authorities and public health teams, so really important to make the most of those. And I think this can be really important in promoting inclusion and addressing inequity, which I think is really important locally. So I think that's my last slide. So happy to take any questions. Okay, so Richard, would you like to ask the question?
Yeah, thank you, Helen, and team. Really interesting presentation. My route into academia is totally through lived experience, through blue light in veteran mental health, suicide prevention, working with communities and being part of that community on that journey myself. And I'm now an embedded researcher, and been in role almost 2 years. Brought what I've brought with me, which is a lived experience, learning to be an academic, getting on not too bad with that, but I've built up some good relationships with the veteran Muslim and GRT communities in Doncaster, right on the verge of doing some really interesting stuff because barriers have come down, trust is being built, which obviously, as we all know, takes a significant amount of time. But my question to you is, and I'm after pointers from yourself and your team, because I'm coming up against a lack of things are getting lost in translation, I think, between me and some of my academic colleagues. The more academic colleagues, I think, more it's getting lost in translation because I don't talk like an academic and I'm learning to become one. But I'm feeling as if the value and contribution that I can make to the team is being lost. And I'm seeing that more and more. And it happened this week in a presentation and so a project that's ongoing where I really could have contributed and brought the lived experience value to it, and was overlooked, if you like, and it, I don't think it was even a consideration. So I think I feel as if I'm doing something wrong myself. I feel as if I need to adopt another approach to try and engage and to sell myself, if you like, better. So I'm after pointers from yourself in your team or anybody on this call. What other approaches can I consider to try and show the value and the contribution that I'm bringing to a more academic team, please?
That feels like a very big question, Richard.
No pressure.
No, well, I think it's a really important question. And I think, you know, I think in all contexts, we struggle sometimes, don't we, to when we feel like we're on our own saying something and we don't have the support from others. And I think, I wonder if you need people from the communities that you talk about to come along with you and kind of validate your you know, your perspective as a kind of, I guess, white, perhaps middle-aged man. Maybe you need people from your community. But also I think it's about addressing the research culture. Maybe actually it's not about you changing, it's about people thinking about the way that they behave and the way that they respond to ideas and the way that things are presented to them. So I mean, that's my own personal feeling on it, but there may be other people that contribute. But I think maybe looking at some of the frameworks that I showed earlier on in the presentation, so that there's some interesting work being done around the building blocks of communication. And it is a communication tool. It's about how do we find common language? How do we talk about things in a way that we can all make sense of? So I would, I think the slides are going to be shared. So I would perhaps have a little look at that and see if that might be of use too, just around this kind of developing a common language.
Thank you for that. Would I be in order emailing you as well and just discussing that at length going forward, please?
I'm sure that will be fine. Yes, we can.
Thank you.
I don't know if there were any questions in the chat, Nicola. I haven't really been able to keep an eye on that.
Yep, there's a couple of questions and comments, and Richard, just to signpost to a little note that Kasha's put on there as well for you to get in contact with Kasha at the Specialist Centre. So if you check the chat once we're finished with this call. So just scrolling up the chat, Saga, I don't know if you want to come in on camera and ask your question, but you've referenced about supporting individuals, and so those that are offering to share their lived experience, is there any emotional or training or financial support that they should be offered?
Yeah, just regarding one of a project we have been starting, and the specific object is to gather the lived experience of some vulnerable population. So I was just thinking to continue, give them an encourage our kind of motivation, or do we need to offer any kind of financial incentives or any emotional support or any training how to tackle with certain kind of the issues they are having? So what kind of support actually we need to provide depends upon what circumstances.
Yeah, I mean, there is a lot of guidance out there now from the NHR and other organisations involved around how you should, how you should do this kind of engagement. Even down to how much money you should pay people, if they're involved in an advisory group or involved in the research not as participants. So there is advice out there. I would say my experience is that it's our ethical duty to make sure that people can engage in the way that maximizes their ability to participate. So I think you really do need to be asking your asking your community, what do you need? This is what we'd like to do. What are some of your training needs? And I think, there's lots of actually good resources out there that are free around, online training. What is research, or what is PPIE? So you can look at free resources. So if you're applying for PHR funding, there are pots of money to help you sort of do development work or to build community, to build kind of community engagement. Maybe Nicola or Alex could post a bit more information about that. But certainly I would say, you're saying the right things, you're doing the right things, making sure that people have adequate training and that they, are incentivized or paid for their time, I think is really critical. Resourcing that can be difficult, I understand that, but I think, if you can find pots of money or bits and pieces locally, or if you can apply for grants, I think increasingly now there's more opportunities. People are recognising the importance of that kind of work.
Thank you.
I'm conscious of time, so I'll draw things to a close. Saga, we've also popped in the chat a webinar that's scheduled for September that you might be interested in joining. And that is around ethical practice and public involvement and engagement. It's Felicity Shenton that's presenting that. She's a really experienced public and community participation manager and has got decades of experience and lots of examples that she'll share. So just a quick plug for that. I've also popped in the chat our intranet site, there's a huge host of resource on there as well. And if you're wanting some help navigating that, please get in touch with the Specialist Centre and we'll be happy to walk you through the different things that are available there. So huge thanks to Helen. Thank you so much for an informative webinar. It was great to have those examples of local authority work and the shared experiences that we've got as well about finding that common language and actually listening to the human story, not assuming that the data is giving you everything. So really combining those mixed methods of getting to the heart of the matter. It was really, really excellent. Thank you. The slides will be emailed out as along with the YouTube version of the recording, and there'll also be an evaluation form on there. We'd really appreciate your feedback. It's helping us shape the offer in the Specialist Centre. So any feedback or ideas for next training sessions will be very much appreciated. And a really quick reminder about the actual next webinar that's in the series. That's on the 7th of July. That is an introduction to health economics. It's very sort of light touch introduction level. It's a half hour, 7th of July, 10:30 till 11. And you'll find on our intranet as well all of the links to the webinars that are scheduled and recorded. So thank you very much for everybody for participating and for making the experience and the chat and questions so rich and bringing that together, pulling that together for us. And Helen, thank you once again for your presentation and hope to see you all again soon. Thank you.